All right, let's get started. Good evening, everyone, and thank you for joining us for COVID-19 updates. My name is Nicole Hart, and I will be your host throughout the webinar. We will get started with the presentation in just a moment, but first I have a few announcements. All attendees will remain muted throughout the presentation to ensure good audio quality for everyone. We are recording this webinar, and we will archive the recording on our website within the next few days. If you have questions during the presentation, please type them into the question box located in your control panel on the right side of your screen. We will do our best to address as many questions as possible during the Q&A session immediately following the presentation. Please note we will address questions related to the webinar topic. If you have specific medical questions, we ask that you follow up with your healthcare team. Also, please note that the PKD Foundation does not offer medical advice, and the information shared during this webinar is for your information and not intended to be a substitute for consultations with your healthcare team. Care and treatment decisions related to your health must be made in consultation with your healthcare team. I am delighted to introduce you to our speaker, Dr. Dana Miskulin. Dr. Miskulin is a nephrologist at Tufts Medical Center in Boston, Massachusetts. She sees patients in the ADPKD Specialty Clinic and serves as an investigator for clinical trials in ADPKD at the Tufts Medical Center site.
All right. Good evening, everybody. Thanks for joining. So this is what we're going to talk about today. First, the issue of third dose immunosuppressed transplant patient. What is the rationale behind this? And do we have any data looking at patients who have received a third dose? We do, so I'll show you that. Then I'm going to talk briefly about the Delta variant and what we know about vaccine effectiveness for the Delta variant. This is all studies in non-transplant patients. We don't have studies in transplant patients. And then we'll talk briefly about booster doses, the current knowledge about those, and finally about what precautions should one take in the face of the variants that are evolving. Okay, next slide. Okay, so first I'm going to show you the data from quite a while ago now, May of 2021. This is a fast-moving field. There's papers out every week, big papers coming out. So that's good news. We're learning a lot. But this was one of the original papers. This is from Johns Hopkins group looking at the antibody response. That's how most of these papers have measured vaccine effectiveness to 2 doses of the mRNA vaccine. So at the top right there, you can see that antibodies levels were tested 30 days after the second dose. That's pretty typical of these studies. Half the people received approximately Moderna, 53% received Pfizer. And this study was conducted in the registry at this center, Johns Hopkins. Not everyone had a kidney, but most of their kidneys. You can see the numbers here. And what I'm showing you in this red circled part is the number who achieved some response to the vaccine, so have some detectable antibody, and you can see it's divided into those who have no response to either dose 1 or dose 2. That's the first column. So 168 kidney transplants, or 52% of them, are getting no seroresponse. 37% have no response to the first dose, but do have a response to a second dose. And then 11% had a response to both the first and second dose. So this was cause for concern. A full 50% of these immunosuppressed solid organ transplant patients, it varies by organ, but for kidney it's at least 50%, aren't responding to vaccines. Okay, next slide, please. This is in contrast to the general population, as you know, where the response rates were very high, in the order of 95% plus for serology. Okay, so here's a study from the summer looking at 99 patients. This is from France, actually, all of whom were given Pfizer vaccine, and it was given at 0, 1, and 3 months. So they got 3 doses, and we're looking at the responsiveness to the third dose. So that graph on the left-hand side is showing the prevalence of having detectable antibody. And you can see before the first dose, nobody has it. After the second dose, before the second dose, so it's looking at response to first dose, about 10%, goes up to 40%. after the second dose. And the final column represents the response to the third dose. It goes up further quite nicely. So we're up to nearly 70%. So very encouraging. People who didn't respond to the second dose do respond to the third dose, and that's listed in the text on the right-hand side there. So among 59 patients who had been seronegative before the third dose, a full 26 of them, 44%, had a seroresponse at 4 weeks later. And all 40 patients who had been seropositive the second dose were still seropositive after the third dose. And their antibody titers increased dramatically. So that's what's shown in the right-hand graph there. The orange bar represents the median, so the average, and this is the distribution of the antibody titers. You can see it goes up with each dose, but there's really a marked increase from the second to third dose, which is great to see. The patients who did not have an antibody response in this study tended to be older, had a higher degree of immunosuppression, and had a lower GFR than the patients who had a response. Okay, next slide. This is another little study from England, only 10 patients. These were all patients who had not responded to the first 2 doses of mRNA vaccine and received a third dose. The first 2 doses happened to be Pfizer, the third dose was Moderna. 60% of these seroconverted, so got a response finally to that third dose. And the interesting thing about this paper, I thought, was they also looked at T-cell responses, and you may have heard this talked about. The former data I've shown you here in these studies has only looked at the antibody response, but there's another part to your immune system that is the T-cell responses. And so this study looked specifically at T-cell responses and found that in 9 out of 10 of these subjects, there were some robust increases in T-cell responses. And these T-cell responses were very similar to what has been seen in healthy individuals, which is reassuring. Next slide, please. Okay, here's just serologies, and this one has T cells as well. This is from Canada, just came out this summer, August. It was posted in New England Journal. This study uses a little bit of a higher titer to denote seroconversion, so showing a positive antibody response. It's actually higher than anybody else has used. They're requiring you to have an assay level of 100. Other studies have required 50 with this assay. So the prevalence rate of seroresponse is a little lower than what I'd showed you earlier, about 55% of this population. And these were not selected for having not responded to the prior 2 doses. This is just they had, I think it was over 150 patients who received 3 doses. 55% get a robust, like 100 micro or unit per milliliter response or above after third dose, versus 18% of placebo-treated patients. This is a randomized clinical trial. You can just see the distribution of the antibody levels. The orange in the top panel A represents antibody to RBD. That's the main spike protein that these vaccines are generating immune responses against. The blue is representing people who got placebo. And these doses were given at the 4th month. So 0 is the first it gives you some idea of what the immune system looks like, the humoral immune system, at least in that placebo group. You're getting some sense of what the immunity looks like, even if you don't give any vaccine at 4 months. Most of these people don't have adequate antibody. And then panel C shows you neutralization. This is pretty much what it sounds like. So neutralization is that you're actually stopping the virus from replicating in vivo. And what's considered positive or substantial, like eliciting a satisfactory immune response, would be a 30% response. That's that dotted line. And you can see the placebo people don't have that at all. Those blue columns represent those at 4 months who got a placebo. They aren't able to neutralize virus. Well, you can see those who got the booster have quite a nice ability to do that. And then that panel D is just showing you more of this T cell specific responses. So it's seen in the placebo group. It's interesting. We had said earlier, some of these placebo group patients didn't respond. We can see their antibody levels in panel A didn't have a humoral response, but they surely do have a T cell response. And it's even stronger, of course, after the third dose. Next slide, please. Okay, and one of you or somebody who had heard about this topic had written in and asked a question, do we have any data about whether this vaccine actually works? And it's a fair question because everything I'm showing you is about antibody levels and T cell subsets generated towards this virus and stuff that we figure out in a lab. What about clinical efficacy, reducing cases and hospitalizations and deaths and all that? It turns out that those are harder studies to do. Those require very large populations and careful ascertainment of those outcomes. You have to really follow people closely, make sure you capture all those outcomes, and that is difficult to do. So we don't have any studies like this specifically in transplant patients that were done prospectively. What we have here, I was able to find one study. It's a retrospective study. So it was based out of University of San Diego, looking at their, again, solid organ transplant registry. And I've showed you the numbers here. So they compare the rates of COVID cases, so getting COVID infection, hospitalization. In 912 vaccinated patients, they all had 2 doses of an mRNA vaccine. Most of these were Moderna-treated patients versus 1239 controls. 40, and these controls are all solid organ transplants, but not just kidney. There are other organs. In this study, 45% is kidney transplant recipients. Median follow-up of time of 100 days, not terribly long, but as I say, it's tough to do these studies and better than nothing. And in this 100 days, there were 65 cases of symptomatic COVID. 4 were in fully vaccinated patients. And here you can see below this incident rates of symptomatic infection. This takes into consideration the length of follow-up of each patient. And you can see 0.065 cases per 1,000 patient days at risk in the vaccinated patients, as compared with 0.34 per 1,000 patient days at risk in unvaccinated patients. And that calculates out to about an 80% reduction. Precisely estimate effects on COVID-related hospitalizations or deaths in this study, but at least it's some data here that's showing that yes, we are seeing that these vaccines work for reducing clinical events as well in transplant patients. And this, of course, is just with 2 doses of vaccine. Okay, next slide, please. Okay, and based on all of this, late August, the CDC came out with guidance recommending that individuals who are immunosuppressed, and the conditions included are listed here, but most of what we're going to see in clinical medicine is number 2, and especially in this audience, is recipients of solid organ transplant taking immunosuppression therapy. Based on the suboptimal response to 2 doses of the mRNA vaccines, it is recommended that individuals receive a 3rd dose. A good number of patients who weren't responding to 2 doses actually getting a response at the 3rd dose. So that's encouraging. Next slide, please. So what about those who received the Janssen vaccine? That's J&J's vaccine. That vaccine is an adenovirus vector-based vaccine. And as you know, you only need 1 dose of that. It turns out that the CDC is not recommending a 2nd dose at this time. They don't have enough data to adjudicate this question. However, I did see today in the New York Times that there is a study that's coming out looking at 2 doses of the Johnson & Johnson vaccine. Mind you, that's in the general population, not in transplant patients. But I think that will give the FDA some information about safety of receiving 2 doses of J&J. So I at this point, no, the recommendation is not to get another a 3rd dose for transplant patients or anyone else. And I expect we'll see some guidance on this with the data that's coming out from J&J this week. Okay, next slide, please. A great question came in again from one of you about whether or not you should get antibody testing to help you decide if you should get another dose of vaccine. And the main problem with this is that we don't know the level of antibody that confers immunity. The other piece is that there's many assays available, and they need to be standardized in order to arrive at this level of antibody response. That hasn't been done yet. And then another point that is being made is that, and I've already alluded to this, the antibody response is only one aspect of the immune response. There are T cell responses, and we don't have a great understanding of how much this influences immunity. So at this point, we're not suggesting to obtain antibody testing. Next slide, please. So we're going to switch gears, talk about the Delta variant of SARS-CoV-2. This variant first appeared in India approximately February of 2021. It's characterized by spike protein mutations. I put a little picture of the coronavirus, what it looks like schematically below. The pink things are the spikes, and they're very antigenic, so they stimulate the immune system robustly, and it is towards these spike antigens, or the crowns of the coronavirus, that these vaccines are directing the immune system response at. So if there's too much of a mutation in the spike proteins, then the virus will evade the immune system immunity that's developed with prior vaccines is a concern. This particular Delta variant also has a mutation at the S12 cleavage site, which may enhance its replication. And this could lead to higher viral loads, increased transmission. I think this is now definitely considered well established. This Delta variant is considered to be approximately twice as contagious as the original Alpha strain. And then another question that can be asked, although it remains unanswered, is do these mutations affect virulence, i.e. the severity of disease once infected? Next slide, please. So if you're interested in knowing what's going on in the US with terms of what variants are circulating at any given time, it turns out there's a great website you can go to, it's listed below, that shows you how the circulating strains are evolving over time. And if you look at the furthest leftmost column, it's dated 6/5/21. The turquoise bar represents the Alpha strains. That was the original strain to which these vaccines were directed against. The orange B1617.2 is the Delta strain, and it rapidly has become the predominant circulating strain in the US. As of late June, it was responsible for 50% of circulating strains in the US. Next slide, please. Okay, so what do we know about the effectiveness of these vaccines against the Delta variant? We have a few studies now. This first one is from Europe. This is actually England. And what we're looking at here is a negative case control study. So using the national health system there, they looked at all people who came in and got tested for symptoms of COVID and compared the ones who ended up being positive against those who were negative on the PCR test, okay? And then looked to see how many of the positive ones had been vaccinated as compared to the negative ones. And that they just define as vaccine efficacy. And here they've broken this chart, the y-axis you can see is on a scale of 0 to 100, and they've broken the chart up into 3 groups: any vaccine having received BNT16TB2, that's the Pfizer vaccine, and ChAdOx happens to be AstraZeneca, which is similar, although not identical, but similar in concept. It's a vector-based vaccine, similar to J&J. So you can see results for dose 1 and dose 2. Dose 1, we're getting, and the results are further divided as to whether the strain genotype was the Alpha or Delta variant. So these are symptomatic infections, people going to get tested, inpatient or outpatient, for COVID. And you can see dose 1, we're about 50% efficacy for Pfizer vaccine against Alpha and about 40% against the Delta variant. ChAdOx is in the same order, maybe a little bit lower for the Delta variant. But after dose 2, this goes way up. I've listed the numbers exactly, the exact numbers on the right-hand side there. So after 2 doses, Pfizer is giving 94% protection against Alpha and 88% against Delta. So it's a little bit reduced, but it's not horrendous. And AstraZeneca, you can see the numbers, 75% against Alpha, 66% against Delta. So looks like these vaccines are providing some strong immunity even against the vaccine based on this study. Next slide, please. And here's another one of these types of study. This is looking at vaccine effectiveness in Ontario, Canada. These are, again, symptomatic cases, people going for PCR tests. And again, the comparison, the left-hand graph is alpha strain, delta strain is the purple one to the right. And it compares 3 vaccines, Pfizer, Moderna, and AstraZeneca. There's not a whole lot of data for Delta, but for Alpha, you can see that Moderna looks to be a little bit more effective than Pfizer, after the second dose, which is the black box plots, compared to the gray is the first dose, the black is the second dose. You can see that we're having 92% of effectiveness against symptomatic infection with Moderna versus 89 for Pfizer, so a little bit better for the Alpha strain. Chadox is way down, 64. Delta strain, again, not terrible numbers. Don't have an estimate for Moderna. There weren't enough patients, but it's 87% effective against Delta compared to 89 for Pfizer. That's pretty darn good. Next slide, please. And these are data from the COVID-NAT surveillance program in the United States. So this is basically a surveillance project where they're capturing all the COVID-19 cases in labs that are part of this surveillance network around the country, hospitalizations and deaths by vaccine status, 13 US jurisdictions. It's between April 4th and July 17th. And the first graph shows you COVID-19 infections, so cases, PCR positive cases. The middle one is hospitalizations, the last one is deaths, and the x-axis is week. The blue line, vertical line on all these graphs represents when Delta becomes the predominant strain in the United States. We already said it's about the last week of June. And the point that these authors made was that, yes, we can see there is an increase in cases after June, after that vertical line, that left-hand most graph. You can see that cases are going up, although they're going up in the controls as well. The black lines represent, they're going up, the unvaccinated represents black, the blue lines represent the vaccinated patients. But they were also going up in the fully vaccinated patients. That's probably the Delta effect. But the key point they make is severe disease, which is defined as hospitalizations or deaths, are not really changing over time. So this should also be considered encouraging to people about the effectiveness of these vaccines against Delta. Next slide, please. Okay, we're going to talk about another issue. It's actually difficult to distinguish when a person gets a COVID infection or hospitalization or death, in August, September, October, and coming into October, and think a question that can be asked, is this because of a different strain, or is this because the immunity to the original vaccine is waning? And that's difficult to distinguish, but this remains a key question. FDA are reviewing this all right now, and we'll probably come up with a decision this week about who needs a booster. And I just wanted to give you some definitions to start off. What is a booster versus a third dose? A booster is an additional dose given to people who were considered have had a good response to vaccine but whose immunity has waned. So it's usually given months after a second dose. A third dose is given to people who do not exhibit a response to the initial vaccine. That's what we discussed earlier in the transplant population. That's usually given much shorter than 28 days or second month after the second dose. Okay, so the bit about boosters, highly controversial. Let's go to the next slide, please. I can show you some recent studies that's coming out about immunity and waning and vaccine effectiveness late out. This is the Pfizer randomized clinical trial, the original clinical trial that was done that the FDA approved this drug on, this vaccine on. So randomized, so you have the blue people receiving placebo, the orange group is receiving the Pfizer vaccine. These are fully vaccinated to 2 doses. So time 0 is a time after receipt of 2 doses of either placebo or the Pfizer vaccine. And you can see this graph goes way out. We're out to beyond 6 months here. And yes, we can see that orange line is increasing somewhat over time. So we're having, these are symptomatic cases. That's the endpoint here. And in the text below this graph, there's a measure of vaccine efficacy at various time points. And the last row of this text, it's really small, sorry, but it's the only way I could get on this slide. But if you look at vaccine effectiveness greater than 4 months after receipt of second dose, 84% effective, as compared with the peak, which was seen greater than 7 days, but less than 2 months after the second dose, 96%. So there's definitely some reduction in vaccine effectiveness that we're seeing even in the randomized clinical trial population at 6 months. This is on average at 6 months after receipt of the second dose. And these authors are actually, this is a paper from Pfizer itself. So they recommended that everyone receive a second dose. Next slide, please. A booster dose based on these data, because there's a reduction in vaccine that's being seen at late 6 months. So they're saying across the board, everyone needs a third dose in the United States and everywhere. Okay, here's just another bit of data that's came out September 17th, last week. As I say, this is a very fast moving field, looking at vaccine effectiveness late out and comparing the different vaccines. And just if you look at the title of this table, these are COVID-19 associated hospitalizations in adults without immunocompromising conditions. This is again that COVID surveillance network. And I circled the red stuff. This is the most important part. Vaccine effectiveness against severe disease, i.e. as defined by COVID-19 hospitalization. And that's obviously a different outcome than I just showed you from that New England Journal paper, which was symptomatic cases. Okay, this is hospitalization, such much greater level of severity here. And you see these vaccines have shown really great response, like reduction in severe disease. So Moderna it seems to hold its effectiveness even greater than 120 days after full vaccine, that third line there of within the Moderna subgroup, right? 92% effective versus 93% within the first 4 months. So it doesn't seem to be losing its effectiveness, the Moderna vaccine. Pfizer is losing it a little bit. So the peak effectiveness against hospitalization, 91% reduction in hospitalization. It goes down to 77% after 4 months. J&J is much lower in all these things. This has already been talked about, but we're seeing they don't have data out to 120 days, but about 68% protective against hospitalization. And I think this has been the basis of much of the debate is these vaccines are providing great immunity. Yes, we're seeing an increase in cases, but we're not seeing an increase in severe diseases, at least for Moderna and arguably for Pfizer, although that remains a point of controversy. Next slide, please. This is just interesting. It's from that same paper because it provides one of the few studies that happens, and I've said it before, and I think this also is supporting of this idea that the antibody response really seems to correlate with clinical effectiveness. So here you can see J&J's vaccine is less, even also an antibody response as compared with the other two vaccines. Next slide, please. And then this is a study looking at nursing home residents within the United States and vaccine effectiveness in this population, and it's less, as is not unexpected, than has been seen in the general population. So they've divided this into pre-Delta, intermediate Delta. Again, one can't be certain whether this is influence of Delta variant or just time and antibody waning. You see the circled part there. The vaccine is only 75% effective. This is against hospitalization. no, sorry, symptomatic cases, and it drops down to 53% in this population in period 3, which is longer, further follow-up. Next slide, please. So I'll show you this one last slide of data. This is a letter that just came out in England Journal last week, and it's looking at the effects of giving a third dose to, these are immunocompetent patients. So these people do not have immunocompromising conditions. And it's a busy slide here, but they're looking at various strains, and these are all in vitro tests. So this is serum neutralization titer. This is ability of your serum to neutralize the virus, i.e. prevent its replication. And that dotted line represents the level which is considered an adequate immune response. Below this, you don't have immunity to this virus, is how I would think about this. And the green bars represent the alpha strain, the orange is the beta. So this top graph is, let's focus on that first. And we can see that these graphs are split up into age groups. So the left-hand set of columns represents people under age 55. The right-hand is the older population. And this shows you the immunoresponse to each dose. So before the first dose, the first column, 7 days after dose 2, we get a nice robust response to both strains, alpha and the beta. 1 month after dose 2, nice response. And then before dose 3, and they gave this dose 3, this is the interesting part, 7 to 8 months later. So we're looking far out at antibody waning. You can see it's dropped down, but for these young people, it's still a lot of them are above this. 83% have have adequate ability to neutralize the virus, at least the alpha strain. Then they give these people again at 7 to 8 months. They're giving them a third dose, and you can see that there's a huge response. And a point that's being made here in this paper, this letter, is that it appears that the response to the third dose is even greater than the response that was seen at the second dose, so quite exponentially higher, which is nice to see. So that's the young people. I think an important point made by this letter is when you look at the older people, they're getting close, and for the beta strain, they're at before dose 3, so this would be on average 7 to 8 months after receiving full vaccination. This is with the Pfizer vaccine. A lot of these people don't have adequate immunity to this virus anymore. And when they give these people the third dose, you can see how robust that immune response is pretty much the same as was seen in the younger people. I think this is one of the key points that is being made to the FDA. There was an advisory panel that met last week and advised the FDA that we should be giving a third dose to people over 65 or individuals with comorbid conditions and anything that would lead them to have less of an immune response. For example, that nursing home population I showed you. And they're reviewing all this stuff right now, but I think these data are quite influential. And just the graph below, we don't need to spend time on this, but it's just showing you what happens with the Delta variant. And these vaccines seem to elicit the similar immune response to the alpha as to the Delta variant. So not a great reduction in immunity at all. I mean, they're on par, all these plots. And again, you can see this is comparing 1 month after dose 2, 1 month after dose 3. It seems that there's even a more robust response. So each time you give this vaccine, you're getting an even greater response to the vaccine, is what these data suggest. It's a pretty small study. It's only 12 patients, but interesting data. Okay, next slide, please. So as you know, several countries, for example, Israel has already given their people over 60 the third dose. Britain and Germany will be doing it. Are administering boosters to older patients. Advisors the FDA recommend a booster to adults greater than 65 last week, and people who are considered to have reduced immune systems. And we expect a decision on this from the FDA week of September 20th, this week. What about people with chronic kidney disease? We don't know. We do know in dialysis patients that the initial response to vaccines is very robust. 85 to 95% of them are making an immune response, but there's no published data here, but I happen to know some data from our dialysis provider, Dialysis Clinic, Inc., and we're seeing that the antibody titers are waning. And so we're actually giving our dialysis patients a third dose now. And I think the closer you are to dialysis, i.e. the lower your GFR, the lower your immune response is likely to be. We don't have any studies in CKD populations looking at level of GFR and how robust immune responses or how effective these vaccines are. So we basically have to extrapolate what we know from the general population and aging and this nursing home population, I guess, and also the dialysis population. So I'd say probably individuals who are in CKD stage 5, maybe 4, especially if you have other comorbid conditions besides PKD, you would, and you're not over age 65, because I think we're going to hear that over age 65 across the board are going to, it is going to be recommended they get the third dose. I think people in those groups, I think it definitely one would consider it. We'll have to see the specific language that comes out from the FDA upon it, but about this, but I figure it's going to say something like this. Individuals with chronic conditions, which I would put CKD there. PKD itself shouldn't increase your risk. It's the reduction in your kidney function that impairs your immune system response, but that's not seen till late, as I'm saying, usually stage 4 or 5 CKD. Okay, next slide, please. How do I protect myself? Most important thing is to get vaccinated and stay in touch with the news about whether you are a candidate for the third dose. If you're a transplant patient right now, you should already be getting your third dose. A very important part of this is to reduce your risk from close contacts and family members, and the best way to do that is to have them get vaccinated. Guidance about mask is listed here. And I accessed this September 20. This is changing frequently, so you pretty much need to look at the CDC website to find out the latest recommendations on this. It's also always in the news, but right now, fully vaccinated. If they are fully vaccinated in an area with substantial or high transmission, i.e. places that are densely populated, which you should avoid, I would recommend, and people with weakened immune systems. And in general, I would say until we have this virus under control, which I don't think we do at all right now, people should practice social distancing, especially if immunocompromised. All right, next slide, please. That's it. And I'm happy to take your questions.
Thank you so much. That was a lot of information. You were very correct when you said there's been a lot of information that's out there at this time. So we do have some questions. Let's get to a couple that were submitted before the webinar. For transplant patients that have had 3 doses of Pfizer or Moderna vaccine and have had a negative result on an antibody test, does this mean they do not need to have, or they do not have immunity to COVID-19?
I don't think we absolutely know the answer to this. I would say that you definitely don't have the immune protection that would allow you not to wear a mask. For example, you need to be very careful. If you've not made any antibody to these vaccines, you should consider yourself very much unvaccinated in terms of how you practice social distancing, wearing masks and all this. What we aren't able to measure is your T cell responses, and you may have some immunity provided by your T cell system, but we don't have measures of that. And so you need to practice all these precautions to prevent yourself from getting COVID-19, I would say, in that circumstance.
Okay. Should patients that have received Pfizer or Moderna and have negative antibody tests consider getting the Johnson & Johnson vaccine?
No, the FDA are not recommending that. Just a personal opinion on this, opinion only, is that the J&J vaccine looks to be less robust in terms of eliciting immune response, and I've showed you some of those data today, than the mRNA vaccines. But really, and I'm not an expert on these things. I only read the papers here and there. So what I'm going to say to you is, I advise you to follow the CDC recommendations on this. It is their recommendation not to get a J&J vaccine after failing to respond to the mRNA vaccines.
Okay, so I know you touched on this and you showed us some great slides, but we did get a question. Do you have data regarding how well the third vaccine is working for transplant recipients? Is there anything else you'd like to add to that one?
Yeah, I showed you some of the data. There's at least 3 papers out now looking simply at seroresponse, antibody levels. But it looks great. So, among non-responders, that one study, I think it was from France, the first one I showed you, non-responders, so they make no antibody the first 2 doses, 40% of them actually responded to the 3rd dose. So that 3rd dose really seems to trigger the immune system. That's sort of been a common theme here with all of these booster and 3rd dose studies, is with each additional dose, it looks like the immune system is getting stimulated even more. Antibody titers are going higher. People who previously didn't seroconvert are converting. So seroresponse-wise, these 3rd doses of vaccine look to be doing something, definitely. Clinical effectiveness, we have no clue. Again, those studies are really hard to do. You need huge numbers of patients, and you need to follow them really closely to identify all the COVID cases and hospitalization. That's gonna be hard to do.
Mm-hmm.
But I will say this, there's a lot of data out there saying that the seroresponse very much correlates with clinical effectiveness. So I think we can use that as our best guess at that they're gonna be effective with more of a seroresponse.
Okay. What is the mortality rate for transplant recipients that are vaccinated but get COVID-19?
Oh, goodness. I actually do not know that. I'm sorry, I actually do not know that. I'm not sure if that has been reported.
That's okay.
That, actually.
That's okay. We can keep it in mind for, additional webinars coming up later. Let me look at what we have coming in from our viewers tonight. I think you covered this, but let me just ask it again, because I think this definitely has come through in several questions. We have someone that has shared that her GFR is 25 and she's 65 years old, and she got the Pfizer vaccine. Should she get a 3rd dose? It doesn't say.
You'll be hearing from the FDA this week on this issue. They're deciding this week, or it will be next week. The advisory panel of the FDA, who just met last Friday, recommended people over 65 and those with conditions that would reduce their immune response, and that's ill-defined, but I suspect we'll have some greater definition once the regulation or recommendation come out from FDA officially, that they should get we're going to call it a booster dose. So my guess, and again, I really think we need to listen to the FDA on this, is that yes, you should get a booster dose. So wait, this week you'll be hearing about this, pretty sure.
Okay, thank you. We'll be listening. Can you talk about monoclonal antibodies? What is this used for, and which patients should be considered?
Yeah, the monoclonal antibodies are used in the face of an acute COVID-19 symptomatic, obviously, infection. And in individuals, you need to use them as early as you can. Usually people who are showing signs of more severe disease and are going to likely require hospitalization, it's to prevent that. So that's the space. Essentially, here's what I recommend my patients, and especially if they're immunocompromised or older, have low GFR, they would be at greater risk for having a severe course of their COVID-19. At our hospital, we have a clinic that evaluates all the patients for what treatment we should give them. Since we just say, no, you don't need any treatment for your COVID-19, but those who we expect are going to have a more severe course, we'll give them the antibody. So if you get COVID-19, you're a transplant patient, I would call your I'm not sure who, your nephrologist probably is who I would suggest, and ask them, should you be getting the monoclonal antibody? The earlier you get it, the more effective it is.
Okay, thank you for that. So my next two questions are very specific, and I'm going to go ahead and read them this way because I think everybody has a situation and are wondering, you know, is it safe to do this? Is it safe to do that? So let's get your reaction to a couple of scenarios here. Our daughter teaches second grade and is fully vaccinated. My wife also fully vaccinated. I am immunosuppressed following a kidney transplant and am fully vaccinated. This person has had 3 doses of Pfizer. Can our daughter visit us, and can she, is it safe for her to come in the house and stay overnight?
Yeah, tough one.
I know.
I
It's very tough, but this is what everybody wants to know. What can I do? What am I safe doing?
Yeah. Yeah. I would say that situation that you're probably safe because your daughter's fully vaccinated. She's wearing masks. Kids are wearing masks, I hope. But she's fully vaccinated. She's younger, presumably. She's going to have a very robust immune response. I would think that the risk of transmission from your daughter is very low. So I would think that activity would be okay.
Okay. And any other recommendations about visiting with friends, indoors, outdoors, with masks, without? It's another question about visiting with friends outside. Is that safe without masks?
Yeah, I mean, the guidance from CDC is that it is. But I think you use your common sense. You want to have these people, ideally these people are going to be vaccinated. If they're not vaccinating, keep your distance is what I think, quite honestly. You want to stay 6 feet away from them, even outdoors. I mean, there's ventilation, obviously. It's diluted out by you being out in the fresh air, but the Delta variant is very contagious. So I think you need to be careful. I would try to limit your activities to vaccinated people and do it outside. And if they aren't vaccinated and you're outside, keep your distance is what I'd say. And I would wear a mask myself in that situation.
Okay, that's a good point. So you're suggesting if you're immunosuppressed, you wear a mask when you're around groups of people. Yes.
Well, absolutely, yeah.
Okay, so this one, have you recommended monoclonal antibodies pre-exposure prophylaxis using the compassionate use program if they have not built any antibodies after 3 doses?
Oh, I haven't, and I'm not a real expert on these monoclonal antibodies, I have to say. But they don't last very long. Okay. And so, you know, it's a very short-lived protection you get from these antibodies. You know, and so it's not like you can go every few weeks and get a dose of the antibodies, to my knowledge, to give you some immunity. It really is for symptomatic cases, early symptomatic cases, where it is most effective. And I've never heard it. Again, excuse me, I'm not an expert on these monoclonals, but I've never heard of giving it in that situation.
Okay, thank you.
Like prophylactically in somebody who had showed no response to the 3rd dose.
Okay, I just got another question coming in. Is there any data on those that are previously unvaccinated but have had COVID? Does this, you know, what does this do as far as transmission to immunocompromised patients? Can you comment on that?
Yeah, okay. So previously infected with COVID usually creates a very robust immune response and gets an even bigger response to the vaccines. You know, once your infection has resolved, you're not going to be infectious to another person. Usually that's thought to be 10 days after the onset of symptoms. You could go even, if you're still having symptoms, I would be careful. But yeah, you shouldn't be transmitting the COVID once you've cleared the infection, which again is on average about 10 days after onset of symptoms. You won't be contagious to other individuals if that's the question.
Okay.
And such individuals are supposed to wait 90 days to receive their first dose of vaccine. 90 days after onset of your COVID infection before you get your first dose. If you have had 2 doses and you're one of these individuals that the FDA recommends a 3rd dose for next week, for example, and you've had COVID, again, the guidance will be that you wait 90 days after your last dose of vaccine to get the next dose.
Okay, thank you.
But usually previously infected people make an excellent response to the vaccines because their immune system has been primed. And the more symptomatic you are, the more robust that immune response is typically.
Okay, thank you. I don't have any more questions right now. Are there any final thoughts that you'd like to share?
I would just say to people to read your newspaper because most of the information I get about COVID, quite honestly, comes from the newspaper. In New York Times, actually, there's references to all of the studies that are influencing policy, and the other would be the CDC website, and I've listed it on these slides, which will give you the latest updates about whether you should be wearing masks in what situation, and also whether you're a candidate for a booster dose.
Okay, and I'll add to that, we do have information on our website. If you just go to pkdcure.org, there's a purple stripe across the top of the page, and that will link you to all of the information that we have, and we do update that regularly. I had one more question come in. I'll ask you this one, and then that will be all the time I believe we have for questions. If a person had COVID-19 and is choosing not to get a vaccine, will that person continue to have a response and be unlikely to transmit COVID?
So the only way you can transmit COVID is if you have COVID actively replicating inside you, which is not the, that isn't going to be the case usually after 10 days after onset of symptoms in most people. So you're not going to be able to transmit it. The COVID's long gone. Your immunity to COVID wanes though, and it is recommended that you get vaccine. Even you, despite having had COVID infection, your immune system will wane, and you are better. Like you are very much recommended to get 2 doses of mRNA or the 1 dose of J&J vaccines. You should get vaccinated even if you've had COVID.
Okay, thank you very much. I just want to thank you for taking the time to prepare this talk and share all this information. It's incredibly valuable to stay up to date. So thank you very much for joining us tonight and sharing all of this information. Registration for the Walk for PKD is now open. You can visit walkforpkd.org to find a virtual walk near you and register to join us for the 10-day virtual challenge, October 8th through the 17th. Thank you again, Dr. Miskulin. That was wonderful. I appreciate the information.
Oh, thank you.
Take care.
Thanks for joining, everybody. My pleasure. Yep. You too.
Good night.